Uh, yes, so my first case is about a 60 years old female with no medical history presenting with paroxysmal palpitations. The echocardiography was normal with no structural heart disease. The resting ECG shows a sinus rhythm, a normal P wave, a normal PR interval, a narrow QRS, and no sign of pre-excitation. The ECG recorded during the tachycardia episode, we observed a regular narrow QRS tachycardia, one-to-one atrioventricular relation with RP interval longer than PR, and we observe a negative P wave in inferior leads, positive in V1, negative in G1 and AVL, with a P wave in V1 longer than 80 milliseconds. Following the atrial tachycardia localization algorithm, we have a P wave that is positive in V1 and negative in EVL. It's a left atrial focus. P in V1 is longer than 80 milliseconds. There is a high probability that the origin is from left superior pulmonary vein or left inferior pulmonary vein. A decapolar catheter is positioned in a coronary sinus. CS910 is the proximal part and CS12 is the distal part. Another catheter is positioned in the right atrium around the tricuspid annulus. The EKG in the beginning of the procedure was similar to the resting EKG. There is no broad sinus P wave or intra-atrial conduction delay suggesting a macro-reentrant tachycardia. There is no pre-excitation suggesting EVRT, and there is no sign of dual AVN physiology suggesting AVNRT. So the tachycardia was induced after catheter positioning without any ventricular or atrial stimulation, starting with an atrial premature beat similar to the tachycardia P wave. We note that CS and right atrium catheter were inverted in the position and that we switched later. This is the EKG of the tachycardia, which corresponds to clinical tachycardia with the same P wave morphology. Intracardiac activation mapping shows significant portion of the tachycardia cycle length without recorded atrial activity, and atrial activation time is markedly less than the tachycardia cycle length, as we see in our case. While in macro-reentrant tachycardia, we found a prolonged conduction so that activation of the entire chamber can extend over or even exceed the entire tachycardia cycle length. In this case, P-wave morphology and atrial activation sequence depend on the site of the origin of the tachycardia. Here we have an atrial activation that started from CS12, corresponding to the distal part of CS catheter, and then from the right atrium 1-2 to right atrium 9-10, suggesting an origin from left pulmonary veins. The PR interval during atrial tachycardia is appropriate for the atrial tachycardia rate and usually longer than those in during sinus rhythm. Here we have a PR interval at 2015 milliseconds. It's longer than the one during sinus rhythm, with an RP interval longer than PR interval. Oscillation of ventricular cycle length occur frequently during atrial tachycardia and is the result of changes either in the atrial cycle length or EVN conduction. In addition, spontaneous changes in the PR and RP interval with fixed AA interval favor atrial tachycardia. In our case, we observe a variation of tachycardia cycle length. In the first picture, we have a tachycardia cycle length at 4092 milliseconds, and in the second case, a tachycardia cycle length at 4036 milliseconds. The ventricular atrial linking following cessation of overdrive pacing with 1-1 AV conduction during focal atrial tachycardia, the VA interval between the last captured QRS complex and the first atrial tachycardia complex that is equal to 2094 milliseconds that vary from the VA interval during atrial tachycardia, and that is 2080 milliseconds. And that's because the timing of the atrial return cycle is not related to the preceding QRS. In contrast, in the setting of typical AV-in-RT or orthodromic AV-RT, the post-pacing ventricular atrial interval remain fixed and similar to that during tachycardia, with less than 10 millisecond variation after different attempts at atrial entertainment of SVT, because the timing of atrial activation is related to or depend on ventricular activation and is not the result of retrograde VA activation over the AVN fast pathway or the bypass tracts in the AVRT. Then we do the differential site atrial pacing that can help to distinguish atrial tachycardia from other mechanism of SVT. Overdrive pacing was performed here in our case during tachycardia from different atrial sites, from CS56 as we see in the first picture and CS12 in the second one. At the same pacing cycle length, 40,000, 50 milliseconds. We confirm first the presence of 1-1 AV conduction during atrial pacing, and the SVT resumes following cessation of pacing. Then we measure in different pacing sites the difference in the post-pacing VA interval from the last captured ventricular electrogram to the earliest atrial electrogram of the initial tachycardia beats, and it's equal to 2094 milliseconds in CS56 and 2062 milliseconds in CS12. The difference is more than 14 milliseconds, and it's evocating atrial tachycardia. So to explain, is in that the explanation is that in the setting of atrial tachycardia, the first atrial return cycle following cessation of pacing depend on distance between the atrial tachycardia origin and pacing sites, atrial conduction properties, and mode of the resulting response of the atrial tachycardia. And it is not related to the preceding ventricular complex. So the tachycardia ended by atrial incremental pacing. We stopped the procedure because the localization of the atrial tachycardia is left, and that needs a 3D mapping system that we don't have in our EP lab. So the second case is about a 40 years old male with no medical history, presenting with permanent palpitation. The echocardiography shows a reduced ejection fraction, probably related with the arrhythmia, after elimination of the other causes. The ECG, we observe a regular narrow QRS tachycardia with an RP longer than PR. The P wave is isoelectric in EVL and negative in V1 and positive in EVR, and it is negative in all precordial leads. So if we see the algorithm of the localization, P wave is isoelectric in EVL and negative in V1, suggesting a right atrium focus. Positive in EVR, it's coming then from the tricuspid annulus or the septum, and negative P wave in all precordial leads. The most probable diagnosis is atrial tachycardia coming from the tricuspid annulus. Catheter positioning was the same as in the previous case. The starting EKG was similar to the clinical ECG. Intracardiac activation mapping shows significant portion of the tachycardia cycle length without the recorded atrial activity, and atrial activation time is markedly less than the tachycardia cycle length. The activation sequence is starting from distal right atrium catheter 1-2 to proximal right atrium catheter 9-10, and from the proximal CS 9-10 to distal 1-2, which is probably in relation with posterior origin in the tricuspid annulus. The PR interval during atrial tachycardia is longer than that during sinus rhythm, and it's equal to 1098 milliseconds. In this case, we observe also an oscillation in tachycardia cycle length. In this case, we complete the procedure with a programmed ventricular stimulation. Ventricular overdrive pacing at 4030 milliseconds didn't terminate the tachycardia, and the presence of a stable 1-to-1 VA conduction during pacing is verified. The electrocardiogram sequence immediately after the last paced ventricular complex is categorized as a atrial ventricular pattern. So it's a VAAV in our case, which it's evocating a atrial tachycardia. In other SVT, as EVNRT and EVRT, the pattern is VAV. To explain, following overdrive ventricular pacing with 1-to-1 VA conduction during atrial tachycardia, retrograde conduction occurs through the AV nodes. The result is the first retrograde A wave after the last paced V. This P wave is unable to conduct back to the ventricle because the AV node is still refractory to anterograde conduction. The next complex is a new A wave starting again the tachycardia, the atrial tachycardia, and then it's followed by QRS. The result is VAAV ending sequence. Conversely, in the setting of EV in RT or orthodromic EV RT, VA conduction occurs through the retrograde limb of the circuit. The result is the first retrograde P wave after the last paced V. The anterograde limb of the tachycardia circuit is not refractory, so this retrograde P wave can conduct to the ventricle directly. The result is VAV ending sequence. In this case, we complete the EP with conventional mapping in aim to ablate the tachycardia because of the right localization on the tricuspid annulus. While ablation catheter was positioned in the posterior tricuspid annulus, activation time was measured from the onset of the first rapid deflection of the atrial bipolar electrogram, as we see in ablation 1-2, to the onset of the first atrial activation in CS 910. In our case, it's 30 milliseconds, and it's less than 70 milliseconds. In the site of origin of the atrial tachycardia is defined as the site with the earliest pre-systolic bipolar recording, in which the distal tip shows the earliest intrinsic deflection. So we see it in ablation 1-2. After mapping the right side, we started ablation with radio frequency, and the result, as it is shown, is a sinus rhythm and primary success of atrial tachycardia ablation. And thank you.
Thank you very much, Dr. Hussam. Very excellent two cases using conventional ablation, which is the standard in most Africa. And Dr. Rusasi showed us how to use the 3D mapping. Thank you very much. We reached. Do we have any questions from the audience? Okay, we reached our final session. It's 8 o'clock now. I would like to invite you to attend the working group of pacing headed by Dr. Bisrat, who is going to, Dr. Ahmed Jawda from Libya, is going to give us an interview to the types of pacing as you can use it for the general population. Thank you very much for attending. And